bed rest is not advised. In fact, we say early ambulation as soon as feasible. That is grade 1A. And then the treatment is anticoagulation. I'll take you through the steps, and these are the guidelines of the chest and the ACCP 2008 and 2016. Basically, we start with a heparin, unfractionated or now low molecular heparin, and convert it to one of the oral anticoagulants. Earlier, the vitamin K antagonist, and now the direct acting oral anticoagulants. So heparin used to be the mainstay. It is the mainstay of therapy, whether unfractionated or low molecular weight, which is followed by an oral anticoagulant, which till some time back used to be warfarin. But now, for very obvious reasons, we have stopped using it. Instead of plain heparin, now we use low molecular weight heparin. So I will not take much time on this. And various studies have very clearly shown that low molecular weight heparin is superior to unfractionated, both in efficacy and in monitoring. So that's about the low molecular heparins. These are the various low molecular heparins available to us. The brand name, the generic name, the manufacturer, the doses for treatment and the doses for prophylaxis are given over here. Vitamin K antagonists have several limitations. As we all know, that is unpredictable response, narrow window, need monitoring, etc. And so many drug-drug and drug-food interactions. And all of these factors have been removed more or less by newer or novel or direct anticoagulation. So that's about the direct oral anticoagulants. And the commonest we use are rivaroxaban, Xarelto, and dabigatran or Pradaxa. And these, you can see, there are different places where they work, where they attack the process, and that's mentioned over here. We'll be having another class on just on novel anticoagulants. So that's how we treat them. Initially, 0 to 5 days, we give them parenteral anticoagulant, heparin, low molecular heparin. And then we switch over. Earlier, we used to switch over to vitamin K antagonist. Now we switch over to novel or direct anticoagulants. So which are these? Dabigatran and rivaroxaban are the most commonly used. There is a risk of bleeding, and it's at the moment only dabigatran which has antidote. Now the various trials, and just touching an overview of the novel anticoagulants versus the vitamin K antagonists. So brown is Pradaxa, dabigatran, that is the RECOVER trial. Rivaroxaban is yellow, that is Einstein DVT and Einstein PE trial. Green is apixaban. So these are the trials which have told us, shown us very clearly that the novel anticoagulants work much better than what we were using previously. So there is no question about that. They are now the standard of care. Let's say like the Einstein trial showed us that it was rivaroxaban was non-inferior to the low molecular heparin and vitamin K antagonist combination and had better safety profile. And the dose, again, we are all very much aware of, 15 milligram BD for 20 milligram once a day. Now, all of these drugs, the oral anticoagulants, are approved, as you can see, for India, and we have all been using them depending on our preferences. Okay, now how do we use them? You start with a low molecular heparin or unfractionated heparin for up 0 to 5 days, and then you shift over. Earlier, we used to shift over to vitamin K antagonist. Now you shift over to dabigatran after 5 days, 150 milligram BD. Or this is a very good change that you can, without giving the heparin, you can straight away give rivaroxaban 15 milligram BD for 21 days and then switch to oral. And similarly for apixaban, you can do that. So again, just making that a little clearer. Heparin followed by earlier vitamin K antagonist, and now with the oral anticoagulants after 5 days, or straight away with the oral anticoagulant rivaroxaban. So dosing, I've already told you, for dabigatran 150 BD. For with renal impairment, you have to adjust the dose. Now, one thing which we are worried about is bleeding. Now, I must admit, that in all the years that I have used these anticoagulants, I have personally never seen a bleeding of any significance. I have once used an antagonist, which I'll tell you about, which is something which probably some of us may not be knowing about. So anyway, if there is bleeding, what do? You give a mechanical compression. If that doesn't, and of course you stop the drug. If that doesn't work and it's an internal bleeding, you do an endoscopy and try to control it over there. And of course, fluid replacement you're already doing. But if it's a life-threatening, then you have to give PCC, that is prothrombin complex concentrates. These are activated, plain or activated. These are freeze-dried, human-derived, and they can be used immediately. They are not ABO. You don't need to do a blood grouping. Of course, for dabigatran, you do have an antidote, and very soon probably we are getting one for Xarelto also. Now, something new that I'll tell you, there was this patient who was on rivaroxaban for ongoing or treated DVT, and he needed an emergency heart surgery, and we were worried that he may bleed quite a bit. So we used this device. This is called a cytoscope. It's a very nice, easy to use device. It's like a hemofilter, and you can use it either in the dialysis machine, or since we were operating the patient, you can use it during cardiopulmonary bypass. Well, it's a very simple physical device. It absorbs the Xarelto and just takes it out. And we were expecting severe bleeding, but we had just what bleeding would normally patient would have who was not on anticoagulant. So this is one of the antidote, you could say. Of course, it's quite expensive. Now, this was about treating DVT as such, but now we came across some cases, for example, where there's a large load of clot, where there's a proximal venous thrombus, like iliofemoral. Here, there is one, risk of pulmonary embolism is high. Number two, risk of post-thrombotic syndrome, destruction of the valves, and risk of recurrence is very high. So what do we do over here? So this is just telling you that if you just treat like normally, which I just told you with the oral anticoagulants, you'll still have a large number of patients with chronic venous insufficiency, with venous ulcerations, with venous claudications. And as opposed to this, if you do an active process of actually lysing and removing the clot, then we'll show you the trials which have shown that the results are much better. So the ways of removing it, one is operative, which I'll talk to you about, which is not being done now, and second is endovascular. Second is lysis, which could be systemic, which again is not being done, but we can do it endovascular, which is catheter-directed thrombectomy or thrombolysis, CDT, ultrasound accelerated thrombectomy, or percutaneous mechanical thrombectomy with an angiojet or a trellis, or again something new I'll tell you about, that is the Mcnamara, which we have had the opportunity to use recently. So thrombolysis is, we are reserving it for extensive proximal iliofemoral thrombus. It is still controversial as far as the guidelines go, but most of us who have used it are very happy. Somebody has scratched on the screen. So systemic thrombolysis was used earlier, but the incidence of bleeding was really prohibitive, and systemic thrombolysis is generally not used now. CDT or catheter-directed thrombolysis has a better lysis, better preservation of valve function, and lesser bleeding risk. Reason is you're using a very small dose, you're giving it directly into the clot and it gets metabolized very fast. So this was one of the trials way back in '92, where they compared heparin to lytic drugs, and with heparin there was just 4% resolution, while with lytic drugs it was 45%. Then we had the Kevent trial, catheter-directed thrombolysis versus standard treatment for acute iliofemoral DVT in 2012. And this, it used the Villalta score, which is a very nice scoring system for post-thrombotic syndromes. It has the 5 patient-related symptoms and 6 clinician-related signs. That was a bad cough, and we scored them accordingly. And that's a pretty good way of scoring it. Mr. Sopti, I keep getting this that so and so at the waiting room admit, and it is interfering with my vision. Yeah, thank you. And it was a randomized trial of 209 patients, and basically it showed that the frequency of post-thrombotic syndrome was lesser if you used catheter-directed thrombolysis, and iliofemoral patency by a venogram at 6 months was better. So by using that, we have been using catheter-directed thrombolysis. This is the dose that they had used in the trial, 20 milligram of alteplase versus unfractionated heparin. And that's the result they got, that post-thrombotic syndrome at 24 months was lesser. Iliofemoral patency at 6 months was better. Mr. Sopti, I'm still getting that 3 people have entered the waiting room. It's right in the middle of my screen. Can you please get that off?
Right, sir, I did it.
Thank you. It's still there, actually. Right in the screen. So in spite of the Cavan trial, the guideline was still a little iffy. And they said in patients with acute proximal DVT, they would recommend anticoagulation alone over CDT. That was a grade 2C. But they did say that patients most likely to benefit are those with proximal iliofemoral DVT, acute symptoms, which means 2 weeks, good functional status, life expectancy of more than a year, and a low risk of bleeding. So most of us doing CDT are following these indications. Then, of course, came the Crag trial, which did let a number of people down, but you have to see the results. Acute venous thrombosis, thrombus removal with adjunctive catheter-directed thrombolysis, the Crag trial. It was done, one of them was our friend Vedantam, and it showed that there was really not much difference between doing catheter-directed thrombolysis and not doing. But very soon, when people studied the trial, including our own Professor Alan Davies, who is very dear to VAI, and who in fact presented this at the 13th Vicon in Mumbai. And there are various editorials now in 2019, in January 2018, which all of them have attacked the ATTRACT trial for various lacunae. Number one, it was underpowered. And when you studied the subdivision, you found that in proximal iliofemoral DVT, the trend was better. So they should have not combined the two together. Of course, in femoropopliteal DVT, there was not much advantage of doing a catheter-directed thrombolysis. And they, in the editorial, suggested that in extensive iliofemoral proximal DVT, especially where the symptoms are quite high, patient is young and has a good life expectancy, and the clot is less than 2 weeks old, then they said strongly advise its use in spite of the ATTRACT trial. And they said, let us see the results of the ATTRACT trial at 5 years and 10 years, especially for post-thrombotic syndrome. So that's where we stand with the ATTRACT trial. That was a controversy. So catheter-directed thrombolysis is here to stay. This is how most of us do it. You cannulate the popliteal vein, inject either TPA, reticulase, or Actylis, bolus followed by continuous, and of course you have to very carefully monitor for bleeding. And at the end of it, you have to do a check venogram. The next day, you remove the catheter. It quite often will unmask underlying stenosis, which probably should be dealt with a ballooning and maybe a stenting at the very same sitting. So this is how most of us are doing catheter-directed thrombolysis. Now, when did I start catheter-directed thrombolysis? This was in 2011, 6th February 2011, when we did this, the first workshop in Ludhiana, in Christian Medical College, Ludhiana. And I'm very thankful. There you can see our panelists. Dr. Raj Pinjala is there, and of course Sundaraj and Malay Patel, and I thank Dr. Deki, and of course my dear friend Dr. Rahul, who kick-started the program, and of course we had Ul and our dear late Dr. King, Mark, and Benini. And with this, we really started doing venous procedures in a big way. And we are probably the largest series, other than of Rahul. Rahul is a pioneer. And in Christian Medical College, I really started this endovenous procedures in a big way. And now my colleagues are there. I have retired, and Dr. Pranay, a very promising young surgeon, is there who's continuing the good work. So this is, I'm sure you can recognize a lot of people of VI over here. Dr. Gurjeet, Dr. Rahul, Dr. Edwin. And that was one of the very good conferences. It was a workshop, and we did a huge number of cases over there. It was linked to the conference which Dr. Rahul had conducted. So these are the stalwarts, Ul, late Dr. King, and Benini. And that's a brochure of that. And after the conference, we had a good time. And we took them out, and I'm sure in this conference, me and Rahul will look after you equally or even better. Now, this is the, you can use streptokinase, urokinase also, but we prefer to use either Actilyse, which is Boehringer, or Retilex. I have not found a major difference clinically between, I've used both of them. And this is how we do it. Patient is prone under ultrasound guidance. This is again Christian Medical College. This is my radiologist who did most of my endovascular procedures for me. This is my registrar, Dr. Paul Sudhakar, who's now 9 years down. He's a very renowned neurosurgeon. He went into neurosurgery. So we, under ultrasound guidance with sterile technique, we puncture the popliteal vein. That's the popliteal vein. And then we didn't have the procedure possible in the hybrid cath lab. So we used to do it in the ultrasound room, and then they take the patient to the cath lab. So that's getting the same patient. Now, when we first started it, there was high venous pressure. My radiologist would be very scared. She said, "Oh, I'm sorry, I've hit an artery." But actually, it was not an artery. And the pressure just below, downstream to the clot, is very, very high. You can see over here. And this is with the patient lying down. If the patient was standing up, this should go to 60. So anyway, that's a high venous pressure, and initially scary, of course. And then we put in a sheath, and we put in a catheter, we confirm the diagnosis, and then we start lysing. And along with lysing, again, this is something which most, quite a few of my colleagues, Rahul and Rajiv, Vijay Thakur and Deki Wadia have helped me in this. That is, you lyse it and you suck it, and you can see the amount of blood that you can suck off. So this is the advantage of having people who can guide you even if they are at a remote site. All three have helped me a lot. This is the type of clot you get. And we've been doing this. We have a large series. Okay, that was about catheter-directed thrombolysis. Now, there are some which are mechanical combination. One is a trellis system. I'll just very briefly touch about it. We don't have it. I have not used it. Basically, there are two balloons. You go beyond the clot and the balloons and whole caps, and then you aspirate it with the machine. So that is trellis. It supposedly works well, especially these are useful where you do not want to give, or you cannot give a high dose of thrombolytic, or you can't give a thrombolytic. Now, this is one very unique case which we have done in the hospital I'm working in now. This was a massive pulmonary embolism, along with, of course, pulmonary embolism originates in a leg vein, but quite often we don't find it. So this patient had both in the massive pulmonary and massive iliofemoral. So young, middle-aged lady who had a risk factor that she was on tamoxifen. She had operated for CA breast a year back, diagnosed at DVT in a referring hospital where she was started on heparin but collapsed, and then she was diagnosed with imaging. She was revived, luckily, and then referred to us. So that's the lady, massive pulmonary embolism, massive iliofemoral clot. You can see IVC is still clear, so that is the plus point. And see there, we have cannulated both the left popliteal vein and the right femoral vein. Right femoral vein, we went into the pulmonary artery. Left popliteal vein, we went up to the iliofemoral segment. So we did a double. This is, you can see the clot on the left side there. And on the right side, we went into the pulmonary artery, which also had a huge clot. Luckily, the patient was reasonably stable. This is the type of catheter we use. We have to push the lytic agent into there, the whole length of the clot. So this is called a Crag Mcnamara catheter. It's very useful. Earlier, we just had those multiple hole catheters, but now I'm using this in all my patients. You can see multiple holes. And it's called a weep or spray pulse infusion. So what we do a combination. We give a spray pulse and then a weep. That is, you just give 1 milligram per hour continuously via the catheter. And in this patient, of course, we gave it at both the sides, the pulmonary artery and the Dvt. The sheath, you give some amount of heparin because you may have clotting in the sheath. So after we always do a venogram, you can see a complete lysis, swelling disappeared, patient became fine, and she's on our follow-up. So pharmacomechanical, that is Tellis-like system versus only catheter directed. There are not many trials as such, but generally speaking, results are good. Bleeding is less because you are using less or maybe no lysis, lytic agent, and patient can go home early. But the cost at the moment is prohibitive. This is angiojet, which I have not used, and this has been used by people. What I have used, something again very new in our part of the world, and that's called a Penumbra or a Indigo system. So that's basically a suction device with the addition of a smart thing called a mechanical clot engagement. So you just keep pushing it to disturb the clot, and then with this machine, you are sucking it. So basically, I call it a simple suction catheter, which has gone abroad and done a PhD degree. So that's what it is actually. That's what it is. Advantage is that there is it works very fast. Indication to giving lytic agents. It has recently, last year, December 2019, got a FDA approval. And this is some of very few cases that this is the catheter. It's just a catheter, actually speaking. As I said, it's just a catheter with a little smart adaptation. So one end will go into the clot. So you need an imaging to see where the clot is. So that's a suction which you can adjust the degree of the suction. So that's a canister which collects the clot. And that's the machine. You can adjust the suction over there. You go up on the suction, and then you need a very good dedicated technician, because if you're not in the clot, you'll suddenly aspirate pure blood, and you can lose about 500 ml blood before you even know it. So that's very important to have somebody sitting on the machine. So that's the contraption. That's the pump. That's the single-use device. You put it under guidance in a cath lab, in a hybrid theater. That's what we've done over there. And we hardly, in this patient, I think we did not use any lytic agent. You could use lytic agent also, but it just sucks away the whole clot. There you going up on the suction. I'm quite happy with the device. Only thing it's very, very costly. So that's the clot coming out. You can see the clot. And if you're seeing blood, then you must stop. And there is a locking system over here. So that's the Penumbra device. I'm quite happy with it. If the cost, there you see, clots are coming, but suddenly blood will come, and that means you are not in the clot. And with the separator, you have to keep pushing it so that the separator disturbs the clot. And whether for DVT, pulmonary embolism, or even for arterial thrombus, this is what we got out of the patient. Completion venogram must always be done. It can unmask a stenosis. Then you either balloon it or you can even stent it. That's a must. You must always check. So this is one of the patients who had a May-Thurner syndrome, which we had not actually, we suspected it, but we had not picked it up on our imaging. And after doing the lysis, we found the stenosis and dilated and stented it. So that's about thrombolysis, pharmacomechanical, little bit about IVC filters. Very few indications now. Earlier, maybe 5, 6, 7 years back, I used to use a lot of them. And now, as per the guidelines and as per our own experience, they're very little, like complication of anticoagulation, failure of anticoagulation, recurrent pulmonary embolism. These are the very few indications left of IVC filters. Now, this is one patient we had again in CMC who had postpartum, post-Caesar section, severe proximal iliofemoral DVT. She had pulmonary embolism on CT, although she was not clinically showing any features. It can happen in 1 in 1,000 pregnancies. So in this patient, this was some time back, so we did a catheter-directed thrombolysis. And we also put in a filter through the jugular route. This was a temporary or a retrievable filter. You can see from the neck side we have gone. Filter is there. And then 6 weeks later, we removed the filter. And there her kiddo is going up fast. And that's again one of my registrars who's now a very young dynamic onco surgeon in Mumbai, Dr. Richam. Now, last is very, very, very rarely. In fact, just once I have done it in 30 years, an open surgery to remove the clot. This is a patient, this is from Jalandhar when I was into Gore Heart Care. It is about probably 1996. Patient came with venous gangrene, phlegmasia cerula dolens. And we did not have, at that time, 95, 96, I don't think they were, we had thrombolytic agents. And we just removed the clot with a normal Fogarty's. The leg, just of the toe. That's about surgery. Again, I said just one case I have seen myself, and it's very there. Now, okay. Now we've talked about lower limb. Let's talk a little bit about upper limb. This is the last case. 55-year-old lady. She gives a history of acute swelling of the upper limb, history of prior chemo and radiotherapy for carcinoma right breast. And she was in very severe pain. You can see there is mottling, there is pain, there is swelling. And investigation showed a thrombus in the axillary vein. She already had a CT. We did not need a CT venogram, but she already had it from her referring hospital. Shows the clot. And so we did, there are very little literature about upper extremity DVT. So we just extrapolate what we know about lower extremity to the upper extremity. The procedure is exactly the same. Cannulate the vein, confirm the diagnosis, give the lytic agent. In fact, it has been reported in literature that you can even place a filter. Now, I don't know how you will place a filter in the SVC, but that has been reported because upper extremity DVT can also cause pulmonary embolism. So that's the clot. And we dissolved the clot, everything will look fine. And just before removing the catheter, we did a venogram, showed a residual stenosis, which was probably from the radiotherapy. And then we put in a stent. That's the Evercross stent was put in over there. That's not a very good place to put it in. But then the patient now is almost 10 years and she comes for follow-up. And at that time, for some reason, we were more into vitamin K antagonist, and she was probably she was not affording. I'm not very sure, but she was on acetone, and she's still on acetone, and she's doing pretty well. Now, okay, sorry, there was one more last topic. That's long-term anticoagulation. Why do you want that? In provoked VTE, generally there is less incidence of recurrence because there's a transient factor like surgery, or there is a factor like cancer, which may not be transient, or unprovoked, where you do not know the cause. Unprovoked, higher incidence of recurrence, proximal vein, more incidence, prior DVT, thrombophilia. And these are the patients you have to give long-term treatment. As you can see over here, likelihood of recurrence is very high. If there is recurrence, there can be pulmonary embolism, there can be post-thrombotic syndrome, there can be ulcers, and you can divide them into minor transient risk factors or major. That is, major is where it is unprovoked, you don't know why it happened, and this is a patient who might again get a recurrence. So as you can see over here, if it is a provoked by surgery, you give for 3 months, and if it is unprovoked, you may give for longer, and individualize each patient. Sometimes you may have to give it lifelong. And there is how do you screen? When do you screen? So there is no clear-cut guidelines. There's some things you can see over here. So if it's a young patient, he's had a recurrent pulmonary embolism, or one finding which has been noted is that if you're giving him vitamin K, especially warfarin, and he gets a skin necrosis, it suggests strongly that there's a protein C deficiency. So you should look for it. This is a finding which has been noted. So when to consider testing? Young patient, family members, strong family history, recurrent pulmonary embolism. These are the patients you have to follow up, and then you have to continue the oral anticoagulants, whether vitamin K, or better to use the novel anticoagulants like over here. The dose for Xarelto continues 20, but then you can reduce it to 10 milligram OD for an extended period. Of course, if there are like, even on this dose, she gets a recurrent pulmonary embolism, then you go back to 20 milligrams. Now, need for aspirin, I'm not very convinced, but there are some trials that better to give aspirin than not to give aspirin in the long term. So you can give aspirin for long-term prevention. So you have to balance the risk. At one side, there is bleeding, and this paper, this is called an icon bar, and this paper shows that if you give nothing, there are 10 patients out of 100 will get a recurrence, but they'll be bleeding only in one. If you give vitamin K antagonist, recurrence is reduced, but bleeding increases. So blue is the recurrence, red is the bleeding. While if you give one of the oral anticoagulants like dabigatran, recurrence reduces markedly. So from 10 to 2, and bleeding from 2 with the vitamin K antagonist reduces to 1. So unfortunately, it is not 0. So this is called an icon bar, and it very nicely shows that how you can reduce the incidence of bleeding and reduce the incidence of recurrence also. So for a long term. Now, DVT in cancer is a complete talk in itself. So I'll just touch a little bit that there was this trial, SELECT-D trial, which tried to rivaroxaban versus low molecular heparin, and showed that there was lower recurrence of DVT, but higher bleeding, especially if the patient had esophageal cancer. So if there is a cancer esophagus, then maybe you are better off using a heparin. Outpatient treatment, yes, for the patients who respond very well, you don't need to keep them in hospital, so they can go home on low molecular heparin followed by the DOACs. Compression stockings, I give them to all my patients, but now again, this is controversial whether we should, whether they actually help or not. Like some of these trials have shown that there is absolutely no difference, and especially the GAPS trial, which I showed you at the beginning, which of course is for prophylaxis. But then again, that showed that stockings do not help. I personally am using stockings in my patient. So to conclude, DVT, as I said, is not uncommon. It can lead to pulmonary embolism and post-traumatic syndrome, both of which are very troublesome, can be provoked, can be unprovoked. Risk factors, you should give prophylaxis. Again, prophylaxis in DVT is a complete talk in itself. Diagnosis by clinical pretest clinical and pretest Wells criteria, D-dimer, and imaging, and that will clinch the diagnosis. Treatment is anticoagulants, and along with that, selected patients, you may do a thrombolysis with or without a mechanical device, Ivc filter in very, very, very limited cases. So thank you very much. I know I have exceeded the time. That's why I did not go into pulmonary embolism. I might later if I'm given that. So thank you. And we can go back to no screen sharing. Okay.
Thank you, Dr. Bedi. Dr. Ranjish, would you like to give your comments?
I came across reasonably well.
Yeah. Thank you, sir. Thank you, sir.
Unmute. I'm not able to hear Dr. Pinjala.
Yeah.
Thank you, Dr. Bedi, for that exhaustive talk. Actually, DVT itself is a very, very big topic, and you have touched almost all aspects of DVT. Now, I think the forum is open, and
Mr. Sopti, you'll have to unmute.
Right, sir.
Yes, one comment I want to make.
I can't hear that.
Yes.
You, Dr. Bedi, talked nicely about touching all the aspects.
I don't think anybody can hear you, sir.
Can you hear me?
I can hear you.
Yeah. So it was an exhaustive talk by Dr. Bedi as always. So now I just wanted to have one comment about the upper limb DVT.
Okay.
So we see good number of patients now, especially the renal failure patients who are on one
Okay,
type
I hear you
or
now. Sorry.
other type of catheters who have central lines.
Correct.
And most of these patients we have treated with oral anticoagulants, Novax only.
Okay.
Sometime when there is recurrence or when the response is not good, we investigate them and we have found central vein thrombosis in good number of patients.
Yes.
And
Stenosis also.
yeah, and they would respond well only after we do dilatation of these stenotic areas.
Correct.
Then they will settle. Otherwise, they will keep on getting recurrence of upper limb DVT.
I know. You're right.
Comment. Right. Thank you.
Thank you.
Thank you, dear.
Yes, Dr. Ranjish, you want to ask any question?
Actually, Dr. Bedi is muted, I think. You have to unmute him.
No problem. You can say what you want to say.
No,
There
there
are
are
some,
some.
No, I
there are some questions
hear
chat
you.
also. I think
Yeah.
we can reply you. Yeah.
Dr.
Hello.
Bedi, can you hear? Hello? Dr. Bedi?
I can hear you.
Dr. Panjala, I also have one question. Dr.
Oh, go ahead.
Sandeep Agarwal.
Yeah, Sandeep.
Please go ahead.
See, there are few Novax with which we have to override with the conventional
Heparin.
low molecular weight heparin, and with some we don't have to. We can start from the day one. Why it is so?
Well, the concept of giving initial heparin came from 1986 trials. In 1986, there was a trial saying that they started the oral anticoagulants without heparin, prior heparinization. And they found out the incidence of recurrences were high, non-fatal and fatal pulmonary embolism was also high. But when they gave initial 5 to 7 days heparin and then anticoagulation, the incidence was less of PE and non-fatal and fatal PE. So thereby, it has become standard operating protocol, SOP, that we must give initial heparin and then give oral anticoagulation. But when the newer oral anticoagulants came, the trials were done without the use of initial heparinization for rivaroxaban and apixaban. But for edoxaban and dabigatran, they have not done that kind of trial. They have given initial heparin for dabigatran and edoxaban, then gave the dabigatran. But for rivaroxaban and apixaban, they started with the tablet, they ended with the tablet. So these trials, Einstein study and Amplify study, have shown you can give oral anticoagulant DOAX without prior heparin therapy, and you still get good results. So we have come out of a fixed opinion which we had from 1986 that prior heparinization is necessary. So I think if you see these trials, the trials were designed and proved that they can be effective irrespective of the quantity of thrombus in the deep vein system. You can still get the benefit just by staying with the tablet. Because most of the people and public think that injection is better, injection dissolves the clot blood better than tablets. But it was not true. Tablets also treat well. The larger the thrombus, the better is the action of the tablets. So rivaroxaban and apixaban do not need prior heparinization.
Thank you, sir.
Thank you. Dr. Shoaib Padaria, you have any comments? You have to unmute yourself. Please unmute. You are muted.
Yeah, hi. First of all, Dr. Bedi, thanks for a lovely lecture. Unfortunately, I joined a little late. I had a heavy lunch. I'm so sorry. But yeah, Dr. Pinjala, the point is well taken. However, one thing is there that whether you give unfractionated heparin or low molecular heparin or oral anticoagulation, the clot volume is not really important, because none of these drugs will actually help to dissolve the clot. They are actually anticoagulants. They help to prevent
Dr.
formation of
Shoaib,
new clot.
Dr. Shoaib, I think you have recently did webinar. I think that's why you know the current data.
So basically, the thing is that it is the body's own fibrinolytic system which helps to dissolve the clot.
Correct.
And that's the reason all the trials have shown that thrombolytic drugs will be better in rapid dissolution of existing clot rather than anticoagulants. The role of anticoagulants and DVT is basically to prevent further formation of clot and further extension of pre-existing clot. Now, the question whether parenteral anticoagulation should be given or the oral anticoagulation is as effective early, I think the only answer which I can think of is that by giving parenteral low molecular heparin or unfractionated heparin, the action is more or less immediate. When you give oral anticoagulant drug, it will at least take a few hours after the first dose for the effect to start. That's what my thinking is. I have nothing to back it up, but that's what I think.
No, this point has been raised in the past, and they have found out the tablet rivaroxaban and tablet apixaban reach the circulation in 2 to 3 hours time. So it is as good as injectable low molecular heparin, which is given subcutaneously. Subcutaneously absorption is also not as rapid as intravenous. So the comparison is acceptable.
So here-
Pharmacokinetic and pharmacodynamic studies have shown the orally given tablet rivaroxaban, apixaban are equally good enough in entering the circulation within the short time as you enter with low molecular heparin.
I agree with you as far as the dabigatran and the other drug is concerned. Absolutely. I was just trying to make the point that maybe parenteral drug attacks immediately, and
Yes,
maybe that takes a few hours to act. That's the only thing.
I used to have similar feeling, but after seeing the reports, then I agreed that both are equally good.
True, true.
Dr. Ranjish, it is your turn.
No, so there are some questions in the chat box.
Go ahead. Go ahead. Read it out.
Yeah, there is a case of somebody put a case of hypertension, diabetes with a history of hypertensive thalamic bleed 2 months back.
Yes.
And now there is a left lower limb DVT, and how to do, what to do, and he has started on rivaroxaban 15 mg once a day. So is that
15
okay?
mg once a day.
Once a day he has started because he had a thalamic bleed 2 months back.
What is that?
Vishal,
The
please
disturbance.
mute the speaker, please.
Yes, sir, I did it.
Okay,
Dr.
Dr. Shoaib, any neurologist is inside in the audience? Neurologist?
Answer this question if you want. Dr. Pinjala,
Yeah.
I can answer this question.
Right.
Yeah, please go ahead. Go ahead.
Yeah. Basically, Dr. Bujwai, it all depends upon how big the bleed is. The first question is, because if you have a minor thalamic bleed, normally with the patient has survived, that means most probably it will be a minor thalamic bleed. Normally post 6 weeks of minor thalamic bleed, you can start the anticoagulation. And if it's a thalamic bleed, 2 months later, I will actually stay away from NOACs. I will not start NOACs. I will actually put these patients on warfarin or acetron. That's one of the group of the patients where I will like to use the warfarin and acetron. The reason for that is very simple, because if you have warfarin and acetron, you can actually monitor the anticoagulation, and you can keep the INR somewhere like 1.98 to 2, or to around 2.10. And I also have got an antidote available if the patient has got a recurrent bleed, which normally does not happen. But if I give a rivaroxaban and that also an underdose, so I don't know it is serving the purpose or not. Second is, I don't know what is the age of the patient. Hypertension and diabetes actually will not affect the treatment dose or the treatment way I will treat this patient, but his control of blood pressure, which is very important because he must have a thalamic bleed because of hypertension, so which is very important. Second, the age of the patient is very important. Third is, I will use, as I mentioned, warfarin and acetron. And fourth is, I will also like to do the Doppler again, because sometimes these patients have got only a calf pain DVT when they diagnose on the duplex. And when you do the duplex scan after 2 months, normally this calf pain DVT has already disappeared. And because these patients had a bed, they were on the bed, that's why they got a DVT. and sometimes you don't have to actually use the anticoagulation at all.
Well, Dr. Rahul, I agree with what you said, but in the recent past, there is also an option with dabigatran in these patients because there is an antidote which can reverse the anticoagulant effect in 5 minutes time by 95%.
Yeah.
In fact, those patients who are on dabigatran, when they developed a stroke, that's why I asked for neurologists, when they developed a stroke, they reverse the dabigatran effect by idarosizumab, praxibine, and then give thrombolytic therapy for the stroke. And then afterwards, they put them back on dabigatran. I think that is a convenience with the dabigatran. Whereas if you are on if the patient is on warfarin or etc., it will take minimum 3 to 4 days or 5 days for reversal of the effect of old conventional oral anticoagulants. So you cannot treat them.
You can actually, sir, reverse all the things in around half an hour to 1 hour. All the warfarin and acetone, whatever the anticoagulation effect is there. So you can give vitamin K and 4 doses of 4 plasma.
No, even if you give vitamin K, it takes time for the development of the vitamin K dependent coagulation factors. They are not coming just like that. It will take time for them to come up.
So we give 4 units of FFPs along with vitamin K, and you can actually reverse the INR within 1 hour.
No, I said it may be one side of it. The other side of the new regimes are coming. Dabigatran can be given with the available antidote, which can reverse in 5 minutes time. Praxibine 5 grams, 2.5 grams.
Where this patient is, what sort of facilities are available in this group?
Correct.
You know, antidote is not available everywhere. Like in the whole Punjab, it's only available in 2 places.
That is true. But they are now barking upon the availability of antidote for dabigatran, which no other OX has got.
This whole.
Okay.
There's one question from Dr. Ankit, sir. It's regarding follow-up. Like for a patient, if you have given heparin and patient's symptoms are resolved, do you advise any repeat duplex, or is there any protocol like that for a repeat duplex? Is there any role of a repeat duplex in patients who are treated with improper anticoagulation?
Well, I would generally give a repeat Doppler after 6 months of anticoagulation. At the end of anticoagulation, I would like to do a color Doppler to know the residual thrombus, because there is a direct relationship between the recurrence of DVT and residual thrombosis. Sometimes I do D-dimer, sometimes I combine it with the color Doppler scanning and decide to continue the anticoagulation for extended period of time based upon the degree of residual thrombus. Some people may not like it, but I would generally ask for it at the end of closure of anticoagulation to make sure that the recurrence is limited by well-resoluted DVT. Anybody else would like to comment?
Yeah, because I don't think any guidelines recommend any of those things.
I think 6 monthly follow-up is important. You duplex is the simplest thing you can do. You should do it. We have, may I just ask the chairman, we have Dr. Sriram from Singapore.
Okay. Dr. Sriram, can you hear me?
I can hear you. I can hear you very well. And can I congratulate Harry for a wonderful presentation.
Thank you.
And I have been listening to this. Well, I can't be seen because the host has decided I should not be seen, so that's okay. Just something I wanted to suggest. A lot of questioning has been going on about anticoagulation, monitoring anticoagulation. With the NOACs and DOACs, you no longer need there I'm back. With the DOACs, you no longer need monitoring. With the warfarin and the vitamin K antagonist, you can do INR. There's something that's been changing, and we have been changing this in our practice for almost a year, but this has really come to a head with this COVID business, which is monitoring using fibrinogen levels. The question that came up about the thalamic bleed, the normal fibrinogen level is 200 to 400 milligrams per deciliter. And when we have been doing thrombolysis in the pre-COVID era, we try and keep it between 100 and 150. If you're going too low on the fibrinogen level, you're increasing your bleed risk. And if the fibrinogen level is still over 200, you're probably not thrombolizing enough. So that has been a sort of guide, and you can get fibrinogen levels back within 1 hour. Though there are now point of care testing as well, so you can actually get it in the HDU on the bedside. But with COVID, this has really come to a fore because, as you all know, a lot of COVID patients actually present with disseminated thrombosis. And that thrombosis then has gone on to become DIC. And if their D-dimer levels are more than 2.5, the survival has been 0 worldwide. And fibrinogen is being used now to monitor at what stage of COVID it is, because we are trying to institute very early thrombolysis. Yet at the same time, if we come in a bit too late, then they are no longer in the clotting phase, they are now in the DIC phase. So their fibrinogen levels and their platelet levels are very low. So now trying to do anticoagulation could actually make them bleed to death. So we are using fibrinogen as a monitor much more now and fine-tuning it, as a regular, bedside marker. And this thalamic infarct patient that was suggested, you can monitor the DOACs quite easily with fibrinogen levels. Within about 6 to 8 hours of initiating a DOAC, the fibrinogen levels will start to change, and you have a target. If someone's never had an infarct and there's no risk of bleeding, then you can target 100 to 150. On the other hand, you can target between 200 to 250 or 150 to 200 on the fibrinogen level, whilst you sort of settle in to these patients. You can do the same with warfarin as well. And I both agree and disagree with both Rahul and Dr. Pinjala on the reversal of warfarin. It is true that if you have to give vitamin K, it takes longer to reverse warfarin. But it's also true that if you can put fresh frozen plasma into the patient, you can reverse it, as Rahul says, within an hour or so. So, in the surgical patient, that's what we would use. So my suggestion is to consider fibrinogen levels. They're not expensive, funnily enough, if you want them to be available. And currently the path labs in India appear to be doing very well. India has created the first doctor pathologist who's a world billionaire by just doing COVID testing. So obviously the path labs are doing quite well in India.
I think that's very nice. But you see, problem is, if you look into we also need to look into the costings. If you look into the fibrinogen level, 80 to 90% of the hospital doesn't have the fibrinogen level labs so that they can do the lab.
That was exactly my point, Rahul. It's actually a very cheap test
and we also
to initiate.
To look into
it's probably not used or not done, and we weren't doing it much either, but it's cheaper to do fibrinogen levels. It's just marginally higher than an INR test. It's a question of being available widely, I think. And I guess if as a group we start looking at it, the reagents aren't expensive. That's what I mean. You don't need to buy a whole new ELISA machine.
Now for the dabigatran, there is a CARE program available in India. And in the CARE program, you'll get the antidote free of cost.
Well, that might be an advantage, because if it's not free of cost, the antidote is not cheap.
No, the antidote is 1.6 lakhs. 1.6
It's
lakhs.
not cheap at all. Even in Singapore, it's through the roof.
So it is made freely available to those who have been the members of the CARE program. If you are using dabigatran. So that's why I insist all my patients to get registered for CARE program. In case if they have to get an antidote, they'll get it free.
Yeah. My other point, which I had discussed with Dr. Bedi before this seminar on WhatsApp, is something new that we are beginning to see as a phenomenon, and perhaps across India, you all can start keeping track of this as well, which is completely asymptomatic for COVID patients, totally asymptomatic, never had any of the index symptoms, even no loss of smell or anything, let alone headache and fever, etc. They present with unprovoked DVT. So we've had patients coming in with DVT, never been treated or had any symptoms for COVID, and then you run an antibody test and they're antibody positive.
In other words, you mean to say asymptomatic DVTs?
Well, the first presentation is a limb swelling or limb symptoms. And then we've started running antibody tests, and if they are IgM positive, then by Singapore rules, we are going to have to run a swab. And we've done 6 patients in a week now where they are antibody positive but swab negative for the PCR. So this seems to be some new strange thing going on, that they are in some way a little more
I didn't get you. Are they PCR negative?
Yeah, they are PCR negative, IgM or IgM plus IgG positive.
No, they are pre-symptomatic or asymptomatic.
Well, if they're IgM positive, they could be pre-symptomatic. You're right. Which is why if they're IgM and IgG positive, because IgG doesn't quite rise till the third week.
Second week, yeah, third week.
Yeah, of COVID. If they are IgM only positive, then they will immediately be swabbed, and the swab will be repeated in 4 days. But so far, it's been negative. So these are people who are antibody positive, but swab negative. They're not virus shedders, which means they've had some sort of subclinical exposure.
Very unlikely when compared to the SARS-CoV-1. SARS-CoV-2 is their high shedders. That is the basic difference between SARS-CoV-1 and SARS-CoV-2.
Yeah. But
and that's the reason R0 factor is very high for SARS-CoV-2, which was not the case with CoV-1.
True, which is why I'm saying we seem to be having this odd thing of people who've had subclinical exposure to the virus, who in some way have become hyperthrombotic. And I don't know if you all have noticed that, and it's something worth collecting data on. I've had a discussion with Imperial as well. They've just initiated a trial. With
there are so many special features of COVID-19. In spite of high levels of hypoxia, they are still not symptomatic like the general patients. They are able to tolerate hypoxia better.
Dr. Pinjala, there are a lot of questions there. Please, can you up from the chat?
Let's go. Dr. Ranjish.
Yeah, Dr. Vijay has a question. Actually.
Yeah.
Go ahead.
Yeah, Ram, I have a question. Just on a comment. You said that fibrinogen can be used to monitor the efficacy of OAC or anticoagulation. Is that true?
No, it can be used to monitor the efficacy of thrombolysis.
Yeah,
yes.
It is for
I would like to say, my dear friends, I would like to know the risk of bleeding based upon the fibrinogen. That's how I use it.
Yes. You use fibrinogen levels live repeatedly in order to monitor thrombolysis. When you're talking about oral anticoagulation risk, you can use the fibrinogen levels to assess the degree of risk. Can I initiate oral anticoagulation or not in a patient who may be a high risk of bleed? Does that make sense?
Yeah.
No. See, we have been doing that. Whenever we thrombolyze, we get fibrinogen levels. But here the discussion was about thalamic bleed, OAC and all. So where is there any role of fibrinogen as a marker?
Yes, it is. Yes, there is. Because if they've had a thalamic bleed and they have a lower fibrinogen level, you probably should not be initiating. Remember, there's a range, 200 to 400 in fibrinogen. If you've got someone who's already got a fibrinogen level of 180 to 220, you probably shouldn't be initiating an oral anticoagulant here because the risk of a thalamic bleed is real. On the other hand, if a recurrent thalamic bleed or a hemorrhagic conversion of a thalamic infarct. But on the other hand, if you've got completely normal fibrinogen levels, then you can safely start oral anticoagulation as well. If in someone who has a DVT.
See, there was a trial in Nizam Institute of Medical Sciences sometime back in stroke patients, whether to start low molecular weight heparin, and so how early one can start the low molecular weight heparin. Within a very short period, within 14 days time, they started low molecular weight heparin as a prophylaxis. And so there was no bleed. So the earliest they can start was 14 days. So similarly here, the patient's question was 2 months old history of thalamic bleed. Rahul has said, am I correct, Rahul? The question was 2 months old thalamic bleed.
Bleed, but the DVT is now.
Yeah, that 2 months passed.
Yeah, and the study which you mentioned was they used the prophylactic dose. Now, if the patient has a DVT here, so now we need to use the treatment dose.
Correct.
So we have got an experience of around 40 patients in the last so many years. And so what we have done is, if the patient is within 6 weeks of the bleed, all those patients we have put in the filter. And if the patient has come early with a DVT, and we send these patients home, and we measure and we do the CT scan after 2 weeks. And if the bleed is very small, within 2 weeks, the CT scan shows the healing. We start the patients on prophylactic doses of low molecular weight heparin, only low molecular weight heparin, and not anticoagulation, oral anticoagulations. And then we monitor the patients for another 2 weeks, and we repeat the CT scan after 2 to 4 weeks again. More than 90% of the patient experience settle down if there is a small bleed, and we convert the Clexin or the low molecular weight heparins into the oral anticoagulations.
Okay.
This is a big experience, and by this we have been really very successful.
Okay.
But generally, how many people have actually witnessed or experienced a bleed, major bleed needing some intervention with any of these DOACs?
So DOACs, we had 2 patients last year, not this year. 2 patients last year had an intracranial bleed. One of the patients died.
So now do you put them in
let me say that the incidence of bleed, intracranial bleed, is 0.5 to 1% annually with oral anticoagulants. But with the DOACs, it is significantly less and less with the DOACs compared to the oral anticoagulants. That is very clear. The gastrointestinal bleeds are more with DOACs, but intracranial bleeds are significantly. P-value is more than very significant. P-value is very significant. They are less intracranial bleeds to DOACs. That is very clear.
GI bleed is more in esophageal cancers.
Any cancer patient can have GI bleed.
Esophageal is specifically more for Xarelto, specifically more.
Colonic cancer also is known for it.
Yes, if somebody's got an esophageal cancer with DVT, we do not put them on Xarelto.
Dr. Bedi, a question for you is there. When we have lower limb DVT on the chat, when to treat by thrombolysis and when to treat by NOACs?
You caught him.
It's no.
There are questions on the chat.
It's very clear. It's very clear. If it's a young patient, he's got life expectancy more than a year at least, and it's an acute DVT, and it's iliofemoral. So if it's in the iliofemoral-popliteal, I would not start from.
And then you mentioned low risk of bleeding.
No risk, yes. So these are the very easily, or well, at least you can subjectively see these features or monitor these features and score these features, and then go ahead.
Because attract trial, I think Dr. Sriram is here. He knows he has argued with Ellen in favor of attract.
I'm not in favor of attract at all. I think attract is a piece of rubbish.
I remember.
I have destroyed attract at various sites. To start with, the one feature of attract that most people don't realize on why the PTS and Villalta didn't happen is that 20% of the patients who had in the attract trial were understented. The stents that were used, there was no stent more than 14 mm in size in that stent.
During that period.
Yeah,
yes.
During that period. So every patient's been understented. They've been left with an iatrogenic stenosis for life.
Oh, yes.
That is
well, I think that is also they have grouped the distal DVTs and proximal DVTs together.
Well, they've only followed it up for 2 years. When post-thrombotic syndrome and Villalta score changes do not occur for 5 to 7 years. That's like somebody saying, I smoked for 2 years and I didn't get lung cancer, so smoking doesn't cause.
Analogy, very good analogy.
You have to follow up these patients long enough. And it is true that the attract trial investigators applied for funding to follow up for longer. And their funding was refused because of pressure from the physician side. Because
let's say we'll get one more trial in the near future.
Oh, yes, there will be.
I remember you spoke, and Alan spoke on this in Mumbai, isn't it?
Yes, and Alan was quite upset because he was given the wrong side of the debate. But actually, Alan took the debate up because Nick Morrison could not get his visa.
Okay, that's right.
So he had to take up the debate.
Ranjish, would you like to read the question?
Other questions, most of them are straightforward questions. So I on this thing thrombolysis, correct?
Go ahead.
catheter-directed thrombolysis. Rahul and other people who are doing it more. So do you do it if the patient has come after 2 weeks? Maybe 3 weeks or 4 weeks?
After 3 or 4 weeks, the success is very poor. The success is really in the first 2 weeks. In fact, success is really in the first week. And as you start going past the first week, some sort of mechanical intervention is going to be needed. And by 3 to 4 weeks, I would really resist thrombolysis because you're looking at synechia being formed. So you can use the thrombolysis if all that you want to do is to get some sort of a path through and do a mechanical intervention, but it will be suboptimal. Trying to do thrombolysis for another day for 48 or 72 hours, you're unlikely to thrombolize more and you're likely to bleed more.
So Dr. Rahul, will imaging be of any help to you in deciding that the age of the thrombus? Will imaging, ultrasound imaging will be of any help to you in assessing the age of the thrombus and deciding to do or not to do thrombolysis?
Yes, definitely, because imaging is one of the indications, but doing the imaging in every patient myself and to detect that it is a fibrous, because if it's an echogenic, so if there are shadows and if you're getting a lot of echos, so that means it's a chronic thing, it's a fibrosis. So then I will say it's delayed presentation. So I will not like to do it. I place my thrombolysis only actually on very clinical findings. One is the duration, as Ram said, is very, very important for me. And I actually poke them. Really, you didn't had swelling 2 weeks before, and you were absolutely walking around. So I actually poke them and ask the clinical question. That really gives me a lot of insight into that, because sometimes the patient present 2 weeks back to the clinician, but actually he had a swelling from 6 weeks. This is very common in our scenario. And the second thing is, I look into the funding, because finance is very important, because I have seen, we see around 100 DVT patients a month in our clinic. And so I have seen that our clinical experiences runs in thousands. So, so we see that any patient, if I do a proper anticoagulation and patient follows me up, I've got follow-ups up now more than 10 years. None of those patients has developed a PTS, only on medication.
Oh my God.
Really, none.
Well, that's the end of the ATTRACT trial then.
Okay. The only patient, I can now see the decision on the first day that this patient will develop the PTS at 3 years or not. Only by if you have a massive swelling in the leg.
Male gender,
massive swelling in the leg means involving the whole iliac veins, profunda vein especially, and an SFV, and a calf veins, and the patient requires, he's coming into my clinic, he cannot walk, he comes in a wheelchair or a stretcher.
That is a very useful signal.
I know this patient is going to develop a PTS. So I immediately assess all the parameters so that I can do the thrombolysis. So I will be very pro to do the thrombolysis in this patient.
But by doing thrombolysis, the risk reduction is not so significant.
And all these patients whom we have done the thrombolysis, like we have been doing thrombolysis from 15 years, all those patients on follow-up, none of them has developed the PTS.
Actually, all of us who do thrombolysis are very convinced. ATTRACT trial.
See, Dr. Bedi, I feel the selection of patients is very important.
Obviously.
Because the risk of intervention and the cost of intervention is very high.
No, I agree with you. One point here. How many patients you denied thrombolysis?
Nearly everywhere. If you see, I see 100 patients a month. I used to do 20, then reduced to 10. Now I do like 3 or 4 a month. So you can imagine. So the number.
So you are refusing thrombolysis in 97% of your patients.
95 to 96, because when you read.
That's a very good selection of patients.
Because when you do a thrombolysis a lot, then you have a lot of complications. And our complication rate was very high, because
I think, let's ask Dr. Vijay Thakur. Vijay, how many patients you will do out of 100 patients, thrombolysis? Are you there?
Yeah, I am with you.
Yeah. How many of your patients undergo thrombolysis out of 100 DVT patients?
I think I see 100 DVTs probably in 6 months to 8 months time. And I offer to 70 to 80% of people thrombolysis out of 100.
It's a hard debate. Dr. Sriram, the debate is getting stronger.
And out of 70
Deeper.
to 35 to 40 odd guys get ready for thrombolysis. And sole reason is cost.
But
and what about the PTS in your patients? What about the PTS in your patients?
Unfortunately, I don't have a data of 10 years of those DVT patients.
5 years?
You know, Professor, unlike we are into private practice, we don't get those patients back. But my gut feeling is if my patient is ready, he has all the qualifying criteria, I would go ahead with thrombolysis. And ever since I have an angiojet, probably it could be an
more inclined to be.
Could be an overkill for other colleagues, but I still go for either CDT or.
Well, I think I understand from this, the science is evolving. We are all learning. I think we need some more time to make a decision in this issue. Until then, individual experiences will continue to value the need for thrombolysis.
Vijay,
Ranjish, any more questions?
No, so just one question to Vijay. Sir, Vijay, are you very particular that you won't do thrombolysis after 2 weeks? Like, you know, they come with after 3.
Yes, I've been hearing this. My cutoff line is probably 3 to 4 weeks time also. I've done couple of cases up to 4 weeks time. The caveat is here, in such cases, SFV thrombosis is so bad, do whatever, we are not able to recanalize them well, and synecdoche formation is very bad. But in such cases, if inflow through profunda is good, and if I can fix iliac vein problem, maybe with stenting, with thrombolysis, probably it's a good gain.
I don't do Ivc filter, no?
May I?
Yeah.
I see my friend Dr. Chunga is here. So maybe if we can get him on board and get his views. Dr. Chunga, are you there? And probably Dr. Ayman is also here. Can they hear us? Yeah, Dr. June is there. Yeah.
Let me just put them on.
Yeah. And just look for Dr. Ayman also.
Yeah, I'm looking.
Yes. John is here. John is here.
Yes, put a question in the chat box.
Yeah.
This is Dr. Chunga Jr., nephew of our original Dr. Chunga.
Yes, I know.
Go ahead.
Most of them are called Dr. Chunga there, who do sclerotherapy.
I think in Mohali we'll call them Dr. Changa.
I'm not able to connect.
I put in both them on the videos on.
Okay. So meanwhile, can you ask any question, Dr. Ranjish?
Dr. Penjala, can I make a comment here?
Please go ahead.
So
Please
I
go
was
ahead.
just listening to Ram and Rahul and Harinder and everybody about selection of their patients and Vijay from Baroda. See, we don't get so many patients. We get, let us say, about 10 to 12 patients a month of DVT. Now, the way, we are in a private institution, so cost makes a difference. The important thing is the patient comes with a grossly edematous leg, a very painful leg, a patient who has presented with proximal DVT with absolutely no flow at all. And thirdly, a patient who has already undergone treatment initially for the first 3 to 5 days with no resolution of symptoms. I think these are the patients we'd like to pick up for treatment for thrombolysis. Because many of the patients who present with very proximal DVT and you have given them anticoagulation, if you do an ultrasound at day 5, you will see a significant number of them as recanalized to a great extent. And if you just leave them alone with the medical line of treatment and compression stockings and repeat an ultrasound serially, their edema disappears, pain disappears, recanalization is pretty good. At 3 months, there's a pretty good result. So in those, just to go ahead just with empirical thrombolytic therapy just because thrombolysis is available, I think is not a very good idea. So we tend to wait for first 2 to 3 days, see if the resolution is occurring. If resolution is occurring, then it's fine. Having said all that, and I've been doing thrombolysis since 1993 with streptokinase originally. Now, I can't say that I have not seen any PTS. In spite of the best of results and best of everything, patients do at least persist with some degree of residual ankle edema and little bit of pigmentation. They may not be progressing to ulcer formation, but absolutely normal legs I see in very few patients who have had very bad DVT originally over a period of time. I don't know what the experience of others is.
Shoaib, you said streptokinase from 93. Was that systemic or catheter directed?
Catheter directed.
Oh, really? Well, that's very critical.
I started doing peripheral angioplasty and thrombolysis in 91. Once we got a DSA lab at Just Knock. So we started.
He's one of the first few stalwarts of the treatment.
Sorry?
Very good, very good.
Ranjesh, Dr. Chuna has asked a question.
Yeah.
And you can write that out.
Read it.
Yeah, I can. Dear professors, do you use thromboprophylaxis routinely to perform ultrasound-guided form sclerotherapy?
I think nobody of us is doing that. Maybe
he's asking whether in this COVID-19 pandemic season, is there any extra precautions like that?
Well, in the COVID-19 pandemic season, we are not doing ultrasound-guided form sclerotherapy in Singapore at the moment. At the moment, all our work has been shut down to only emergency work, and elective work is not. And I can't see any need for an emergency sclerotherapy, at least not at this point.
Unless the patient is bleeding.
But it's a fair question, you know. It's a fair question. But all this lockdown business starts opening up, and we start getting used to a COVID world, should we be doing some sort of extra thromboprophylaxis? There's more and more evidence emerging that the virus is essentially, and it begins as an endotheliolitis, and that the lung complications are secondary to an initial endotheliolitis. And we may well end up with a global population whose endothelium is slightly more excitable than we had, say, last year. So yeah, it's a fair question. I don't know the answer to this.
The same thing is important for the EVLT, where there is a risk of HIT.
It could be important for hip surgery. It could be,
HIT is also going to be high.
Even the prophylaxis that people might do when they're doing long-haul flights. We don't know. And a lot of this data is still emerging.
And in the same line, there is one question by Dr. Rajesh Singh. I think he's asking about an Encore surgery. In cancer patients, probably after chemotherapy, in the early postoperative period, there may be thrombocytopenia for a few days, maybe 2 to 5 days. So how do you give prophylaxis, like Clexane prophylaxis in these patients?
Well, cancer in general is still prophylaxed with low molecular weight heparin. In general, we don't do anticoagulation prophylaxis, certainly not in the peri-chemotherapy period with oral anticoagulation as far as possible. So cancer is still prophylaxed but then in the thrombocytopenic patient, HIT is a real risk, especially if they've had some sort of heparin before. And it is, but in general, thromboprophylaxis would be with a low molecular weight heparin in cancer patients, not with an oral anticoagulant.
No, now the new data has come with SELECT-G trial that chlorhexidine is safe in cancer patients also. But I think we just have to wait and see how it goes as the time goes on. We may be considering NOACs also because the data is being generated and the trials are also positive for the direct oral anticoagulants in cancer patients.
So the question was, if it is a transient thrombocytopenia, do we give Clexane?
Yes.
If it is covered very well afterwards, recovered very well afterwards, you can give. And usually 50,000 is the cutoff point for my practice.
For LMWH.
Now, tell me, anybody who's working in institutes where they are treating COVID patients, how many deaths are actually autopsied? Because I don't see who would be doing the autopsy in a COVID patient.
I think whatever the data that we are knowing from NAJM is from China. The autopsies are all from China.
Yeah, Italy probably also. Because of
I think even here burial itself is a
Italy has
issue.
some of the highest. Italy is having some of the highest postmortems.
Yes. Because in India, I don't think anybody would be willing to do it.
Nobody is willing to do it.
Histology has come out of Italy.
I think so.
24 deaths seem to be occurring every hour in other countries. But we have autopsied them all, but the data is extremely under wrap, lock and key Singapore style at the moment.
Correct.
But most of the histology, the endothelialitis, the lung changes, the renal changes, the in situ pulmonary thrombosis as opposed to pulmonary embolism, the non-plaque ruptured myocardial thrombosis,
Myocardial, yes,
coronary
myocardial,
vessels,
MI.
the absence of myocarditis, unlike other viral infections. All this data is coming out of Italy predominantly.
Now we are getting this pediatric inflammatory syndrome.
New disease is being unearthed in New York.
Yeah, fortunately we treat
rashes, red eyes.
Yes.
Yeah,
so
what
we
about?
We are learning a lot about this.
Okay, Ranjish, any more questions?
I don't see any more questions, sir.
Dr. Rahul?
So one take-home point from this is like, if anybody wants to do a trial on DVT in India, I think we should approach Dr. Rahul first.
Correct.
Considering the number of cases he sees.
Oh, you see, that's
yeah, you probably finish your recruitment in about 2 weeks.
No, actually not. You see, we did all the trials with the rivaroxaban, Pedaxa, dabigatran, Hokusai study. We were part of all the international trials, our center. And we had recruitment is very difficult because we were doing the consenting on the video. And once you do the consent properly, genuinely, why our thrombolysis rate is so low? Because before the ATTRACT trial, our thrombolysis rates were very high. Means we used to do at least double. Once the ATTRACT trial published, so people ask me, is there any studies published or is there any data? I tell them that this is the data published and which is shown. The moment you tell them actually that this is the data which is published and one is the only trials, I cannot argue the drawbacks, and that's a clinical thing. But I tell them that this is a small risk involved. Nobody agrees. Very few people agrees for DVT thrombolysis. Very few people. The moment you tell them, even if there is a 0.5% risk of intracranial bleed, 95% of the patients say no.
Well, it is very clear that the patients you have to spend a lot of time explaining the patients if you want to do an invasive procedure.
It's a very difficult job to...
Because thrombolysis is not the end of the story. You may have to do balloon dilatation. You may have to do stenting. You may have to put a filter. So many things are inbuilt in the system. At any time, you may extend your procedure.
And I tell you, thrombolysis, I don't know what people tell. I've done hundreds. We had our share of complications. One patient I remember very well, the whole department shivers, 2.5 years back. This guy was totally fit for thrombolysis. We shifted the patient to table from the trolley, only on the table. And patient was anticoagulated and patient had a P just shifting from, it is bad luck. And, we lost the patient.
Yes, such things happen, sudden deaths.
Sudden deaths, and this could have happened in the ward also, but it becomes a luckily
it's like aneurysm rupturing.
Yeah, luckily we hadn't put in the sheet, and I was like, if we would have put in the sheet, the blame would have gone absolutely on us, everything.
Correct.
And once dealing with attendants in such a situation is very difficult.
Delicate, very delicate.
Private hospitals
so
in
Rahul,
India.
do you put filters in all patients? IVC filter before thrombolysis?
If the patient can afford, I will like to. And if the patient cannot, then I go, because I try to do everything, try to be medical legally right, because there are a lot of data published. You can do the thrombolysis without filter, and a lot of data which the filter should be there. So I can get away with and without.
Why do you not look at it from the point of view of, from the contralateral side, the balloon that you're going to use for angioplasty? Move the balloon up in the IVC while you're doing the thrombolysis, or you're doing the suction thrombectomy part of it, whatever the device you use, deflate the balloon and save the patient the cost of a filter.
Yes, you can. Yeah.
Because I hardly use a filter now.
Dr. Sriram, when you do that, post-procedure patient may develop DVT in the right leg.
No, we only pass it up through the saphenous vein. They don't develop. We haven't had that yet. No.
Because patient will be anticoagulated and thrombolysis TPA will be there. So I don't think patient will develop a clot on the other leg. The only
The
thing
issue is during the mechanical manipulation of the clots, can you get a move? And I agree you could use a filter for that part, but I prefer to use the same balloon. It cuts down the cost.
But when in India, as you know, we can reuse the things, and we had.
So that cuts down the cost even more then.
Yeah, but then the size of the balloon is not really adequate to occlude the entire IVC.
Well, I assume in the common iliac vein, you're going to be using a 16, 18, 20 mm balloon.
No, you can do 24,
16 to 18, I think in Indian patients, at least in Mumbai side, I think more than 18, we don't really find. Maybe Dr. Bedi and Rahul might be seeing larger patients,
Dr. Bedi is 25 himself.
If you have to use it in IVC, the balloon you have to use will be much bigger. It will be like 30 to 40.
Yeah, but
30, 32. But what I'm saying
28
16
is the maximum.
and above is enough to prevent a DVT in the IVC from the IVC, PE from the IVC.
Now, another thing is we got these filters from the environment which we have been using from last 1 year. So this is, you can close it, you can reuse it again. We used it in, and so the last all thrombolysis where we had to use the filter, patient was not agreeing. We were putting this filter from the other side, and it's a plastic thing, and keep it there, do the thrombolysis, and just take the filter out. We used to clean it up, sterilize it, reuse it again. So you can use it around
we've seen that. That looks like the Invamed did send us the brochure, but sadly they're not registered in Singapore yet. But that looks like an extremely good option. A little filter that you unsheath and sheath in and take it out later.
And so it runs around 4 times. It's not of a very good material. It's a very, they did the environment.
We're going to run it only once.
No, of course.
Okay.
But
you got me thinking, like, if you are doing a lysis with a TPA,
we're coming to close.
I would not be bothered about putting a filter. But you got me thinking that if I've just started using in a few cases the Penumbra device. So because that is just sucking it out. So I think there probably you would like a filter because you're not giving lysis. So maybe in a Penumbra where the only thing is suction, nothing else.
Especially the cap.
Yes.
But especially the upper cap, as you're trying to, the risk is real. It's not.
That's why when I'm using Penumbra, I go from the bottom. I keep on sucking the clots from the bottom. And when I reach the iliac vein, then actually with Penumbra, I give TPA. I give 5 milligram TPA and wait for 10 minutes. Then I do the iliac veins.
Very good. Very good.
So it's become a pharmacomechanical thrombectomy again.
Why not? Save the patient. Whatever you do.
Yeah. Wonderful. Okay, we are coming to the end of this session.
Vijay was going to say something, I think.
Vijay? Dr. Vijay? I think he already left.
You are muted.
Maybe he already left for a case, DVT case.
No, sir. He's there. He's talking, but
Vijay, you are muted.
Unmute.
No. There is a program on VSI which is going to start, which I just started. He may have joined there.
No, he's there.
He's there.
He's on. We can see him.
Oh, sorry.
But then we have to unmute him.
Your computer. You have to unmute your computer. Can you unmute yourself?
I've done.
No, it's not.
Yes.
Yeah, Vijay, please.
I think
Vijay's computer is mute.
I
don't
hope
able to
he's
see
not
you,
mute.
hear you.
After
I
listening
suspect
to all of
Vijay
us.
is at home and his wife is somewhere around. So he's naturally muted.
Ram, at least he is doing the webinar with the friend, so he will not be problem.
Hear you, Vijay, but you look lovely.
Okay, Dr. Rahul, would you like to sum up?
Yeah, sure.
Thank you.
First of all, I really like to thank Dr. Bedi, for a wonderful talk and all the problems which are there, which you have, shown us and created an interest in all the panelists and the speakers. And I'd like to thank the panelists, Dr. Pinjala and Dr. Ranjesh for coming and taking part and getting us all in these discussions. I really like to thank all the other guys, Dr. Sarvanan, Dr. Vijay Thakur, Dr. Padaria, Dr. Ram, and for an active discussion, which is definitely required so that we can reach at least some conclusion and we can share our experience. And I really like to all the participants who have joined and raised such interesting questions, and by which we can actually storm ourselves and we can learn from each other. Thank you, everyone. And thank you
everyone.
Bye. Thanks, Dr. Bedi.
Thank you, everyone.
Thanks, Pinjara. Thanks, Ravu.
Thank you.
Thank you.
Thank you,
Thank you, everyone.